internal we call GATT, and also trabeculotomy combined with the trabeculectomy. All of the procedure focus on the same structure, Slan's canal. And traditional trabeculotomy is used trabeculotomy to cut about 6+6 circumference of Slan's canal. The key step is how to easily find Slan's canal for the trabeculotomy. Under the 2/3 thickness scale thread, you can find out the 3 key anatomic landmarks. The blue arrow forward, we call transparent cornea band. The green arrow backward, we call white sclera. Between blue and green arrow, we call blue-gray trabecular meshwork. The Slan's canal is just right on the line the green arrow refer. And we cut here, that is, looks like you can easily find out the cut end of the Slan's canal. The big eyeball is often seen in children. Then how to identify the anatomical structure of the expanded limbus? We should perform the incision behind the expanded limbus and then find the structure. Again, we need to make an incision behind the expanded limbus to find the structure. The second surgery is ab internal microcatheter assisted 360 trabeculotomy. We call MAP. The same like the traditional trabeculotomy, the key step is localize the Slan's canal, like the same one like the traditional trabeculotomy. We need to make sure the microcatheter was placed into one cut end of the canal. The third surgery is gonioscopy assisted transluminal 360 trabeculotomy. We call GATT. We need gonioscopy. We also need illuminate and ITRA system. The key step including several parts. First one, adjusting the patient's head about 40 degrees, and the surgical microscope like 30 degrees or so to an appropriate position. And assisted with the gonioscopy, can see the angle clearly. The most important thing is to recognize the trabecular meshwork under gonioscopy. You need to make sure that the Slan's canal is just behind the trabecular meshwork. You see here, the green arrows refer to trabecular meshwork. The white arrows show the scleral spur, the same like this, very clear. Again, the green arrow is trabecular meshwork, scleral spur, trabecular meshwork, scleral spur, very clearly. Then you can make an incision on the anterior wall of the trabecular meshwork to gain access to the Slan's canal. We call the goniotomy, very clear and beautiful. Then we insert the distal tip of the microcatheter into the Slan's canal. In this part, the hemorrhage is very common. If bleeding a little bit, we can use viscoelastic to stop bleeding and push the clot. If hemorrhage is a lot, we can aspirate to clean it. To make sure the microcatheter was always in the Slan's canal through the visualizing the course of the illuminated tip and with the turning off the light. The children trabeculotomy is more challenging than the adult, no matter limbo-based or phony-based conjunctival incision to form functional filtering bread. But what is the difference for an adult trap? More serious inflammation and wound healing response, and difficult to observe the outcome of the bread in children. And how to prevent and manage the scarring of the wound. There are 3 aspects we need to mention. One is MAC application, surgical technique, and post-surgical massage. The MAC, we need to use higher concentration and longer duration than the adult. And the position and the way of application is the same with the adult. Don't put on the top of the scleral flap, and don't touch the limb and the margin of the conjunctival. And the thinner scleral flap and looser suture of the scleral flap to make more filtration. And post-surgical massage is very important for the infant. We need to teach the parent to do it when the child is asleep, and once or twice a day to make more successful filtering breath formation. And we need to teach the children to massage by themselves to reduce possibility of the scarring. And before and after massage, we need to teach them to how to feel the pressure, soft or hard, and the children always can do well. Trabeculotomy combined with trabeculotomy. I don't think I need to mention too much, but one question you may ask is how to make an incision. Well, as mentioned as what I say, under the 2/3 of scleral flap, you can see 3 very important structures. Traditional trabeculotomy is make a corneal scleral block inside the yellow square. But we need to recommend you to make the corneal scleral block inside the pink square, and then to reduce the complication. And this is our optimal incision. This is trabeculotomy, the incision. So last, we'll talk about the glaucoma devices. I would like to focus on the armored tube implantation. Which incision of the conjunctival will cause least damage and complication? If I use a phonic-based conjunctival incision, I will recommend you to make an incision less than 1 quadrant and make it nicely. And if you use a limbo base, like a 7 to 8 mm away from the limbus, this is the way what I like. This way is very good for the children because no suture here. And after surgery, children will feel very well. And how to apply for the MNC? Don't use the cotton like this because easily curve. Please do it nicely like what I do. And how to puncture and insert the tube correctly and precisely. A position is no good, easily cause bleeding, touched endothelial cell, iris, or the lens. So along with the growth slow, move forward under the superficial sclera. When approaching the limbus, slightly lift up the handle like this. What I refer, use the green arrow and penetrate parallel to the iris. You can do it under autologous scleral flap, or you can cover by autogenous sclera, or directly penetrate it under the superficial sclera at 4 mm away from the limbus. Very nicely, but it's difficult to do it. Okay, is it necessary to do massage after surgery? I think it's very important too, like a trabeculotomy. Please teach the children to learn how to touch the pressure, hard or soft, beside the massage, and massage against the tube position to reduce the possibility of the scar. My favorite armored tube implantation is corneal suspension to fix eyeball, and away from the limbus to incision conjunctival, and 4 mm directly penetrate sclera to insert the tube. And no ligation to the tube, no anterior chamber paracentesis, no viscoelastic substance to maintain the chamber. So this way is very quicker and cell complication happen. I will show you in the video. I actually, for this presentation, I prepared a series of the video according to the time. I think I have 5 minutes, so I will pick 2 GATT, 1 armored tube implantation for you. And all the videos can be watched through my book, the website, to look at it. So let me summarize. Surgical technique and pills are closely related to intraoperative and post-surgical complications. And trial glaucoma surgery is more challenging. And perfect glaucoma surgery is built on a lot of skill, but the presentation just represent personal opinions. So thank you very much. Let me show you my video. Okay. Can you see the video?
No.
Not yet.
Can you see the video?
Not yet.
Not yet. It's okay now?
Yeah.
Okay. I'll show you the two GATT. One is 360 completely, and the second one is 270 degree. And the third is the amateur. So under the gonioscopy, you can see this is a typical outlook of the gonial structure of the congenital glaucoma. The iris highly cover the scales. When you turn off the light, you can see here. Yes. Is it Chinese music, this one? Yeah, it's nicely. Okay, the second one is 270. The Chinese music too is nice or not?
It is.
You like it, right?
Very soft.
Mm. See here, this is a 270, and then stop here and begin to breathing. Cannot move forward. Then I turn 90 degree and then make a cornea incision again. So this is a 270 degree GATT. Okay, the last one is amateur. This is a very big eyeball. You see very thin this scale. This is 8 mm away from the limbus. I think it's very difficult things that now the eyeball is so big and the scale is so thin. In general, we need to use the autogenous to cover. But I just try, I think I can do it. I still try 4 mm away from directly penetrated, and I did it very well. This is what I'm very proud of myself. And this way can save a lot of time. So we measured the diameter, 17 mm, very big. Okay, thank you very much. 15 minutes, right on time.
Thank you, Professor Xiulan Zhang.